talk. In between, I'll request after that Dr. Sonal to run the thing. After you, I'll speak and then go one trauma society. And okay, so Karabi, come and take her. So I'm overwhelmed with one with the faculty by women and the participants also.
Good morning, everyone. I begin with the first talk of today's ocular trauma course. My topic is on update on classification and recent terminology. Devising a classification system in medical science is often challenging task due to the complexity and variability of human anatomy and physiology. To classify all kinds of ocular trauma, one had to add three more categories, which was that of non-mechanical injury, adnexal injury, and destructive globe injuries, which was not included in the previous classification. The current classification of ocular trauma does not incorporate all these three, and a proposed new classification is broader based and comprehensive to allow for classification of a wider range of ocular injuries not covered by the current classification, as a fifth of mechanical injuries involves the ocular adnexa. Now, the BETS classification, which is the Birmingham eye trauma terminology, satisfies all the criteria for standard terminology. It provides a clear definition of all injury types and places each injury type within the framework of the all-comprehensive system. Now, the old classification, which was in 1996 by Kuhn et al., it classified mechanical injuries into closed and open globe injuries, and the closed globe injuries, there was no full thickness wound in the eye, whereas in the open globe there was full thickness, and there were certain terminologies ascribed which I'll just talk to you about. Now, this was the BETS classification, where it was the broader classification was the closed and the open globe injuries. The closed globe was the contusion and the lamellar lacerations, and the open globe injuries was rupture and laceration, which was again further divided into the penetrating, perforating, and the intraocular foreign bodies. So the terms in BET were closed globe injuries, where there was no full thickness injury, open globe, which was a full thickness injury. Closed globe was divided into contusion and lamellar. In the contusion, it was generally a blunt injury, and in the lamellar, it was a partial thickness, generally with a sharp object. And in the open globe varieties, which was full thickness, the rupture was with a blunt object and the lacerations were with a sharp object. Then the three subclassifications of the lacerations was penetrating injury, where there was no exit wound, only an entry wound, perforating injury, where there was both entrance and exit, and an intraocular foreign body, which is a retained intraocular foreign body causing entrance wounds. In 2009, a new classification of ocular trauma was proposed. In this, the general classification was that of local, associated injuries, and cause of injury. Now, the local was subdivided into mechanical and non-mechanical. Now, non-mechanical comprised of chemical, thermal, radiation, and electrical burns, whereas the mechanical injuries was divided into globe injuries, destructive globe injuries, and adnexal injuries. And in the adnexa, it involved the palpebral fissures, the conjunctiva, the lacrimal apparatus, and the orbit. We'll go into the subclassifications of the globe and destructive a little later. And in the general classification where the associated injuries were there, it was associated injuries of the head, facial injuries, and multiple injuries. And the cause was another, whether it was sports related, whether it was a RTA, whether it was industrial, it was due to an assault, agricultural, or daily activities. Now, coming to the subclassification of the global injuries, they are structural and pathological. Now, structural, as the name suggests, they are either problems in the anterior segment, which could involve the cornea, sclera, uvea, lens, or the pupil, and the posterior segment, which involves the retinal choroid, sclera, and the optic nerve. And in the pathological, again, it's subdivided into closed globe and open globe. The same three, contusion, lamellar, and laceration are there, but there is also extraocular foreign body, intramural foreign body, and dislocations. And in the open globe, apart from rupture, penetration, perforation, and IOFB, these are the classifications. Now, the destructive globe injuries where there is a traumatic evisceration by itself, or there is a traumatic enucleation by itself, or there is a full thickness laceration which involves 1/3 of the globe circumference. So you see this general classification of ocular trauma, it involves all the structures and the causative agents and the methodologies of ocular trauma. So you have a very comprehensive system which you can grade it on. So all cases, as I said, these are a repetition of what I've just told you. And this is again a repetition. Now, when you decide on which part the eye is affected, the zone 1 is an injury up to the limbus. From the limbus to 5 millimeters behind is zone 2, and the rest of the sclera is zone 3. And full thickness injuries are seen in this region. So the types you can classify as, the visual acuity is of course very important, whether it has got some perception to no light perception or to good perception also. And pupils, whether there is an RAPD present or there is no RAPD present, and the zone involved, as I mentioned just now. So there was a study by Shukla et al. Where they found that out of all the 535 cases of ocular injury, with the old classification, they were able to classify 364 of the 535 cases. So that means 33% of the cases were missing out in the old classification. But with the current new classification, everything can get classified. So the management is accurate history, examination, entry point, exit point, gonioscopy, fundoscopy, documentation for damaged structures, a CT scan, and MRI contraindicated if there is a metallic foreign body. Now, where the blunt traumas are concerned, it can affect any part of the eye, whether it is the lens or the vitreous or the retina or the choroid, and similar for the penetrating and the perforating injuries. Now, there is something called as an OTS score, which there are no classifications as of now of classifications, investigations, or treatment guidelines. They are internationally standardized and practiced. There are numerous controversies and variability of practice standards to review the relevance and practice of ocular trauma to highlight validated and effective predictive models, and why an OTS is required to predict visual outcome and also to help audit outcomes. There is another thing called as the Abbreviated Injury Scale, which is also a 6-point ordinal scale from minor to maximal. The injury severity score is based on AIS, and it's based on the body region or regions affected, with the face and eyes as important components. So now the OTS score, if you see over here roughly, the raw points are, if it is no PL, it's 60, if it's PL or hand movements, it's 70, and the vision, if it is 20 by 40, it's 100. So this is in order of betterment. And if there is a globe rupture, it is -23, endophthalmitis is -17, perforating injury is -14, retinal detachment is -11, refractive, relative afferent pupillary defect is -10. So a raw score sum is equal to the sum of raw points, which gives you the status of what the visual outcome would be in these people after the repair is done. So you can prognosticate these kind of things. This is the same thing shown in more clearer handwriting. So despite the reported benefits of OTS in children, many a times the OTS goes wrong in children because of the potential development of amblyopia, which is not catered to by the OTS system. Strabismus, refractive errors, or ocular opacities can result in amblyopia in children. If the possibility of amblyopia is not included in this score, then the predictive accuracy of the OTS is compromised. So the authors have incorporated another mathematical model called as a POTS, that is the Pediatric Ophthalmic Traumatic Score, which helps to safely compare the predictive value of children with their injuries and whatever is going to happen thereon from the possibilities of strabismus, amblyopia, etc., to give a reasonable assessment of children with traumatic cataract. Thank you so much for your kind attention. I invite Dr. Natarajan to come and give his talk now. All yours, Aunty.
Thank you, Kerubi, for a wonderful talk on classification. So the Asia-Pacific Ophthalmic Trauma Society, which I am the president, Dr. Rupesh Agarwal and Dr. Andrews from Argentina has made eye gates for entry. So and Dr. Aditya Jyot is a part of that. So the whole idea is to have a standard classification so that we can talk to each other. And mainly for publishing. So now from the Asia Pacific Ophthalmic Trauma Society we are publishing. There is an okay, thank you. So I'm managing ophthalmic trauma is a passion for me right from my undergraduate days because I grew up in the government eye hospital seeing trauma. So my talk is on salvaging, on unsalvageable, operating on no PLIs. So thanks to Ferenc Kuhn, and I don't have any financial interest. So thanks to Ferenc Kuhn, the president of International Society of Ocular Trauma, and my incoming president of ISOT is my friend who's a professor in University of Hull. So the whole idea is, I think when the trauma happens, that's the only place where we can operate on no PLI. So extreme trauma can include any of this, and then so the main idea will be to construct an when an eye is useful, preserve the eye anatomically, and keep the chance of a functional improvement irrespective of an initial complete functional loss. So that's why any bad injury, I say don't do primary enucleation, do something. And recently, about during the COVID, there was a bike accident, and somebody called me. The patient was admitted at night 1 o'clock in Hiranandani Hospital, and they said the eyeball is hanging. So I called the surgeon in the night 1 o'clock and said, do something. And I know that you may not be able to preserve the vision, get back vision, but do something. But somehow they said they could not put back the eye. In the morning when they called me, they said they have enucleated. I felt very bad because the same patient came to me a few days later, asked whether anything can be done. So once the eye is enucleated, you can't do anything. And that's why I think in 1984, despite the common strategy, Dr. Michael Belkin, he is now 80, and he is still, I saw him recently presenting a paper in RO, advised not to enucleate an injured eye only because of the risk of sympathetic ophthalmia, and as long as the patient can be kept under observation. So nowadays with the steroids, we can make sure that the even if sympathetic ophthalmia happens, you can treat them. Only thing is, you also have to know that post-vitreous surgery, I have faced sympathetic ophthalmia rather than post-trauma. But I think we have to know sympathetic ophthalmia can happen, and so one is to prevent while doing the repair, not to have the UVL tissue in the wound so that it does not produce the sympathetic ophthalmia. And you should have the earliest sign in case, for example, 30 years after the injury also sympathetic ophthalmia has been reported. I had a patient who had multiple vitreoretinal surgery for retinal detachment, and she was a young girl. She came with a difficulty in reading at the age of 18. So I knew it was the early sign of sympathetic ophthalmia. I referred him to Dr. Bishwas, who is here, one of the authority. He treated with steroid and the anti-mitotic drugs and treated the sympathetic ophthalmia. The eye is having 6/6. So any eye that had lost the ability to perceive light was considered to be non-repairable in those days. But now, this is again a study published almost 24 years back by Ferenc Kuhn and Bob Morris, who was the president at that time. It was only 20 years ago that Morris reported on their attempts to reconstruct 11 eyes with severe ocular trauma that could not perceive light. The authors succeeded in restoring some function in 7 of the 11 cases. And according to an analysis in the World Eye Injury Registry, 28 eyes of no perception of light in eyes which a reconstruction was attempted. 21 patients regained light perception and 2 ambulatory vision below 20 by 200. This was again published by Bob Morris. And why I'm telling this is in 86, when I was a consultant in Shankarnath, the fellow saw a child with a 6 years old with a vitreous hemorrhage with no PL, and sent the patient back, and somehow they went to many people and came back again and requested for an appointment with me again. And because of this I operated, and you won't believe the child got 6/6 because assessment of no PL in a child was a problem. And I think just because only in trauma with no PL we can operate, and you can imagine the child got 6/6 vision, otherwise the child would have gone blind by not operating. So we need strategic thinking in ocular trauma, and that's what Ferenc Kuhn says. This is a systematic approach, must have its basis in the scientific literature and genuine personal experience, and no dogma involved. And I fully agree with Ferenc Kuhn that the surgeon must not act on a trial and error basis, but according to the plan. So it's like playing soccer. When you play the opposite team, you don't know. And same thing here with the trauma, you don't know what are the problems happening inside the eye. Thus, the decision when to perform vitreous surgery will therefore continue to be made by individual surgeon depending on each patient. So I'm going to talk on this subject with the extreme trauma with the foreign body, suprachoral hemorrhage, and endophthalmitis. So immediate vitrectomy is indicated for post-traumatic endophthalmitis or intraocular foreign body with high risk of infection. So these tendencies usually occur in young males. Retained intraocular foreign body occur in 5 to 40% of all open globe injuries, and overall 20 to 40 or greater visual acuity can be expected in up to 71%. 18% of the posterior segment trauma will have a foreign body. It represents a true emergency. It could be metallic, magnetic or non-magnetic, and non-metallic, and also like the caterpillar hair, nylon, non-metallic like cilia. So again the removal depends on the persistent inflammation, mechanical damage, and the intraretinal foreign body has a hazardous because of the risk of retinal detachment. And I'm just showing you a 25-year-old had a firecracker injury with best corrected visual acuity with no PL, or rather PL with inaccurate projection. Diagnosed the intraocular foreign body in one in anterior chamber and other in retina, and surgery. So you can extend it. So this is not a free paper, so 6 minutes dollar. Okay, no problem. So surgery, diagnosed with intraocular foreign body, one anterior chamber and other on retina. Surgery was planned in 2 sittings. The primary wound repair with the intracameral foreign body removal, intravitreal ceftazidime and vancomycin, followed by lens aspiration and 23 gauge pars plana vitrectomy with the intraocular foreign body removal. So this is after 1 month after the follow-up with the best corrected visual acuity was counting finger 1 meter. But for this you have to work a lot, do several surgeries, but I think it's worth it. Post-traumatic infection endophthalmitis occurs in 2 to 7% of all intraocular injuries, and surgical management is vitrectomy. So the principle is to clear the media, remove the potentially harmful organism load, and simultaneous antibiotic delivery, increase availability and penetration to retina, and removal of the vitreous scaffolding so that traction retinal detachment can be avoided. So vitrectomy many times have to be done with the temporary keratoprosthesis because the cornea is involved, and you can see here a 24-year-old male with a trauma with stone injury 20 days back earlier, and primary corneal perforation done 3 days following the injury, and perception of light was doubtful. Anterior segment had corneal abscess involving the whole of cornea. So one lesson from this patient is whoever sees the patient anywhere in any remote part of the country, I think should do a good wound repair immediately. I know sometimes in a small place where there are only ophthalmologists available and they are worried. I think you have to develop a rapport with the patient, which is difficult. It will take time. Can convince the patient that initial repair is important. There is no guarantee, and you can tell that you are having a liaison with a senior tertiary care center, with the senior surgeon, so that you can tell that's what I've discussed, and do the wound repair with as though the patient will get vision, and send the patient immediately. So Dr. Ferenc recommends we should do the second surgery within 6 days or 100 hours. And that's most important. And you can see here in this, the total cornea after 20 days is terrible. And we actually planned for a keratoprosthesis, but here you see Flarengar's ring was in place. And then the whole eye is necrotic. And I'm doing a open sky vitrectomy because there was no point in putting a temporary keratoprosthesis, because I don't know what I was cutting and removing. It looked like a micro incision, and I had to do a anterior chamber reconstruction by removing the exudative material from the surface of the iris. You can see the entire eye is cleared of the infection as much as possible, and then a PK was done. I think the anterior segment surgeries are done by Dr. Kavita Rao in our place, and the whole idea is to remove the infection and then save the eye. And this patient, we could have done evisceration, but that was the end of it. And I think the only contraindication will be for doing this will be a panophthalmitis when there is a severe painful blind eye. I think we should eviscerate, but otherwise we can do the open sky vitrectomy like this and save the eye. And then the other important problem which we can do with no perception is the suprachoral hemorrhage, particularly following trauma, history of injury with a cricket bat. This patient had a question mark PL, where B scan showed total closed funnel RD with hemorrhagic choroids more in the temporal quadrant. And this is a 34-year-old male with a closed funnel retinal detachment with suprachoral hemorrhage following road traffic accident. You can see the corneal sutures across. And this patient was operated in a peripheral hospital in Bombay, and they said either you go to Hyderabad, Shankaranethralaya, or AIMS, or the three, and then the patient came to me, and the eye was terrible because there was suprachoral hemorrhage. You can see the entire retina from the temporal side was incarcerated to the nasal side, and here you're seeing the bare choroid, and the retina is totally rolled. And when I use the PSC, it's all in the suprachoral space and in the subretinal space. So what I did is remove the suprachoral hemorrhage and then use the chandelier illumination, and then I'm using 2 forceps to open up the closed funnel, almost a 360-degree retinectomy, and remove the subretinal bands which was there. And you'll see that I saw a small opening. Through that I injected a viscoelastic, and then finally used the PSCL to, you'll be seeing it, the flower will open, and the retina, which looks like a closed flower, where you have to open it. And so I'm now using the 2 forceps, now removing all the subretinal membranes using the retinal brush. And so here I'm using forceps to catch the 2 lips of the retina, which is closed like a flower like this, and I separate it using the 2 forceps, and then inject PFCL in between the closed funnel. You can see the retina, now you can see a small opening. I used viscoelastic, and then finally perfluorocarbon liquid through that, and you'll see the entire retina is unrolled like a carpet. So you can see now I use the PFCL, the retina is totally attached. There are folds, so I did a gentle stroke to make sure that you need to learn the tactile sensation through the forceps so that you can mobilize the retina without causing trauma to the retina. Dr. Jovanovic had designed a retinal massager which is 20 gauge. I think we should have something like that. It's a metal blunt instrument so that we can stroke the retina to spread the retina. As you see here under PFCL, I'm spreading, and I've sometimes seen if you remove the PFCL at this stage, again it can crowd. So I didn't want to remove the PFCL, but I wanted to spread the retina under the PFCL. And you can see some part of this suprachoral hemorrhage in the periphery is still there, but and you can see the optic disc is there now. So it took time to, and now again injecting more PFCL to spread the retina so that the retina is flat. And then I'll do a PFCL silicon oil exchange and do a laser all around. And this patient actually got a recurrent PVR under the oil. So I removed the oil, and I did so one more, and again had recurrence, and the patient said, I'm now give up. But I think I don't give up till the time the patient is understanding. I always tell we can discuss any amount of time before surgery, but after surgery there's nothing to discuss. If you are ready, we'll operate. If you're not ready, it's okay. And if you have doubt, you can have for another opinion. And that's what I did when I went to Kashmir, because a lot of no PLIs I operated, and in the militant area, so you have to be, they were very violent, but I think, so don't give up, take risks in your life, and if you win, you may lead, if you lose, you may guide, and I keep winning and I keep losing, and thank you very much. So next you are going to speak. So Neha Goyal could not come this time, so Dr. Neha Goyal's presentation, Dr. Aishwarya will be doing. I request, hi Supriya. So we have a PhD here, Dr. Supriya Dabur from from Madras, who's a consultant with in VHS, right? And now you are looking a quarter of Dr. Kerubi. So welcome, Supriya. Anyway, I am trying to be like her. So I learned from Supriya. Anyway, Aishwarya is going to compensate both Kerubi and Supriya. No.
Thank you, ma'am. Thank you for that introduction, sir. So Neha ma'am couldn't be here, so I'll be presenting her presentation instead of her. So the topic is current concepts in management of traumatic macular holes, to peel or to wait. So just a small introduction about traumatic macular hole. It's commonly seen in young males. The etiology is a closed globe trauma, 1.4%, or open globe injuries, 0.15%. Then laser injury, surgical trauma, lightning strikes, electric shocks are some of the common causes. The prognosis is rather uncertain due to accompanying trauma-induced retinal pathology such as commotio retinae, vitreous hemorrhage, retinal hemorrhage, choroidal rupture, RPE damage, subretinal neovascularization, and fibrosis. So the pathogenesis, there's AP vitreous traction on the fovea causing true loss of foveal tissue, and the equatorial expansion of the globe following the blunt trauma, which results in tangential vitreoretinal forces transmitted to the macula, with centripetal forces separating the neurosensory layers at the fovea. This results in a full thickness hole with a central defect without any loss of foveal tissue. So some clinical pearls. When examining the patient, we should always remember to check for RAPD and angle recession prior to dilatation, because the trauma patients, this is a rule, must, that you should check for angle recession. Then careful periphery examination with indentation to look for retinal breaks or dialysis. Fundus autofluorescence is important to rule out associated RPE damage. OCT should be done. In OCT, we'll see traumatic macular holes are more eccentric or less circular than idiopathic macular holes. The horizontal diameter is more than the vertical diameter, and there is no correlation between visual acuity and the size of the traumatic macular hole. And invaluable for follow-up and monitoring, especially when you're observing it, because in management part for traumatic macular holes, it's a more conservative approach. So OCT is very good for monitoring it. So the conservative management, this rate of spontaneous closure is quite high in these cases. 50% of children and young, 28.6% rate of spontaneous closure in young adults. 37 to 44% within 2 months of injury. And a smaller basal diameter of the macular hole will also give good prognosis. Absence of intraretinal cyst on OCT is also an indicator for spontaneous closure. So there is a picture shown here of the fundus photo and the OCT of how it has closed spontaneously. So conservative management, like I just read out previously. Now the mechanism of spontaneous closure, the glial cell proliferation from the RPE to the basal surface of the hole. If there is an element of AP traction, occurrence of complete BVD will also assist in the hole closure. As commotio resolves, the edges of the hole may return closer to the RPE, resolving the central full thickness defect. Surgical management, the timing is key. Balance between waiting long enough for spontaneous closure but not so long that the likelihood of an anatomical success is reduced. So 1 to 3 months is the best timing to wait. The procedure, MIVS plus PVD induction, ILM peeling, ILM flap or an inverted flap with a gas tamponade, and use of adjuvants like autologous serum, TGF beta 2, platelet concentrate, and even amniotic membrane graft. Prognosis, successful closure rate is of 83% by meta-analysis. A trauma-induced photoreceptor and RPE damage limits the visual potential. These can appear several weeks after the injury. Ellipsoid zone attenuation on preoperative OCT and worse preoperative visual acuity are associated with poorer outcomes. So some studies by Dr. Neha. And the take-home message. Traumatic macular hole is common in young men with closed more than open globe injuries. A careful examination should be done to look for RAPD, angle recession, and peripheral retinal breaks once ascertained that it's a closed globe injury. Eyes with extensive RPE damage on fluorescein fundus autofluorescence and choroidal rupture should avoid being operated upon. Cases in children, young adults with small basal diameter on OCT and absence of intraretinal cyst can be watched for spontaneous closure within 1 to 3 months. So conservative management is preferable, and surgical management will result in successful closure in up to 83% cases if selected wisely. Thank you. Thank you very much. I invite Dr. Supriya ma'am.
Good afternoon, everybody. My talk today was to be followed by Dr. Sonal, but yeah, it just came in. So I'm going to be speaking on management of intraocular foreign body. We all know that ocular trauma is one of those preventable causes of ocular morbidity, and it's a leading cause of monoocular blindness. Not only is it a profound emotional trauma to the patients and their families, treatment is time consuming, it's expensive, and we often know that the results may not be too great. Almost 40% of globe ruptures are associated with retained foreign bodies, and the American Academy of Ophthalmology says that within 24 hours you need to repair the open globes to prevent or reduce the risk of endophthalmitis, and any delay by 24 hours cause a drop in vision by 2 lines on the Snellen chart. So the different types of foreign bodies they could be toxic or they could be inert. So so we don't need to really, when we're treating them, only when we come to management, whether it's inert or toxic, any foreign body, we would aim to remove it. So the toxic ones could be metallic or non-metallic, or the inert ones are metallic like gold and silver. You could leave them in the eye, but they cause other changes, or non-metallic. Now, it can cause mechanical damage because of the force with which it hits the eye, can cause infections, can cause chemical effects, local irritation, and sympathetic ophthalmia, which may come in even much later. It can go from 3 weeks to some cases have been reported even 11 years after the history of trauma. So there are special effects by certain metals, like for example in copper, it causes chalcosis in the eye, causes a Kayser-Fleischer ring, causes sunflower cataract, and you can see this greenish deposition or the refractile deposits in the trabecular meshwork, on the retina, on the eye limb. It has a greenish sheen to it. Now, iron can cause siderosis. It could be direct siderosis around the area of the foreign body, or it could be indirect, whereas it's far away from the foreign body. In the cornea, it can cause some amount of rusting. The iris can lead to heterochromia, as you can see in this patient. Pupil can be mid-dilated, non-reactive. Cataract can be caused. And in the retina, most commonly when you see a patient with uniocular retinitis pigmentosa kind of picture, with all these bony spicules, pigmentary changes in the periphery, arterial attenuation, and the history also, they will give history of decreased vision, peripheral field constriction, but you must try and elicit history of trauma and look for a foreign body. investigate the patient. So history becomes extremely important. Don't rely on your optometrist to get the history. When you have a high suspicion of intraocular foreign body, look for pre-existing ocular conditions that you could probably see an entry wound somewhere that will make you suspicious. And you know that there are certain foreign bodies which may have less chances of infection. If it's a very high volatile foreign body, then because of the sheer force and the heat, sometimes the risk of infection can be a little less. So you need to elicit a proper history. Patient may be asymptomatic or acutely they can come with pain, redness, decrease in vision. You can see entry wounds here. You can see it in the cornea. You can see on the iris a puncture wound. Sometimes you see the foreign body directly in the anterior chamber. You could see localized cataract here. Probably this is the entry, the point of entry. Or you can here also you can see some amount of localized cataract, and you can see a localized foreign body here. In the vitreous, you could have just degenerative changes, or you see hemorrhages, maybe in the vitreous, maybe on the retina, maybe subretinal. Sometimes you see a direct foreign body as in here, or if it's later, it could be a scar, there could be some amount of retinal incarceration out there, or the patient could just present with infection. So how do you detect foreign bodies? So obviously direct visualization would be the best bet. So it could be seen externally. You can see a foreign body here, or inside the eye on the retina you can see one sitting quietly here. So Dr. Sonal is going to cover more details about the various imaging techniques, so I'm not going to get much into it, but X-ray is mainly for radio opaque foreign bodies, CT also radio opaque, and you need to take cuts of more than about 1.5 to 2 millimeters. It helps to differentiate between metallic and non-metallic, and minimal cooperation is required. You don't have to position the way you need to maneuver in an X-ray, sometimes rotate the face, and but sometimes if it's wooden you may miss the foreign body. CT and MRI doesn't give as beautiful images as ultrasound to see the soft tissue defects inside the eye, for example, which is hemorrhage, retinal incarceration, a posterior perforating foreign body, CDs, scleral detachments. All that can be better seen in with ultrasound. But however, if there are multiple foreign bodies, or sometimes very large, it becomes difficult to interpret on an ultrasound. So the general principles of surgery would be careful examination. Even when you're seeing on the slit lamp, make sure assess vision first, because you need to, as Dr. Natarajan said, every no PLI, we don't just give off on them. Initially they may present with no perception of light, but that doesn't mean you give up on that patient. It could be a lot of factors leading to that. So do give every patient the benefit of surgery and the benefit of treatment. So but while examining, be careful. Don't press on the globe, on the eyelids while you're doing your ultrasound. Make sure it's sterile ultrasound and you do it very gently. Give the patient prophylaxis against possible infections. Make sure they get their tetanus toxoid injections. And the primary repair, we have to try and restore the globe integrity, and if possible, ideally we would want to remove the foreign body in the same sitting. So if you have a foreign body, there is an external approach. If you have it embedded externally in the coats, or it's anterior to the equator, for example in this video you can see you can see the sclera being repaired here, and there you can see the foreign body here. So this is under the slit lamp itself you're visualizing, and so this becomes relatively easier, and it's quite a huge foreign body, so you can remove it externally itself, and make sure you close the sclera well with interrupted 7-0 vicryl sutures. When it's in the vitreous, then more non-magnetic can be sometimes difficult to remove. Magnetic, it becomes easier, because metallic, it becomes easier, so that you can remove it with a magnet also. So always when you see a foreign body, you have to clear the vitreous. Do a complete vitrectomy. Don't just go and attack the foreign body first. Release the foreign body of all its vitreous attachments, because that can lead to retinal detachments. Use magnets when possible, use forceps when possible, And there's no one way of treating foreign bodies. Each one is so different, as I'm going to show with subsequent videos. If it's usually less than 5 millimeters, we would prefer to remove it from the extending through the sclerotomy itself that you've entered, the 3-port vitrectomy. Or if it's more than 5 millimeter, you would want to do a limbal section. So this is a large glass foreign body. So initially I wanted to protect the posterior pole because it was such a large, irregular, serrated foreign body. So I tried to put PFCL to protect, but somehow the PFCL was pushing the foreign body and was going all over it. So that didn't really help. So removed the PFCL. Then I tried a sorry, I'm just fast forwarding a bit. It's rendering a little slow, no? Then I tried to use a 3-pronged, because it was quite irregular, tried to use a 3-pronged forceps to get an edge, to get a hold of the foreign body. This is usually helpful for maybe things like pellets that Dr. Natarajan was showing, for those kind of foreign bodies, a little more rounded, spherical ones. So that didn't give me an edge at all on this foreign body. It was a bit smooth, so it wasn't giving me an edge to hold on to. Then we changed, then I moved to the IOL holding forceps. So that has a serrated edge, and that gave me an edge, and I could bring out the foreign body. Sorry, I don't know, it seems to be a bit slow on this. Yeah, so finally managed to get it out, made a scleral tunnel like an SICS, and delivered it through anteriorly through the limbus. And why I'm continuing now, that even once the foreign body is, so always try maintaining the tone in the eye, use your plugs when necessary, close the wounds, and reduce the infusion when you're bringing it out so that it doesn't collapse. And now you can see that there's a capsule still. So we went ahead and put in a intraocular lens for this patient. So even though you can see that it was such a huge glass foreign body, that doesn't mean that the patient was, didn't have visual capability. So with every step in a primary surgery, do as much as you can in the same sitting, because sometimes you may not get another chance also. So we put in a lens also in this patient at the end of surgery. This is a patient in whom we had this is a stone foreign body. The patient also had vitreous hemorrhage and retinal detachment, as you can see, because the stone had caused a retinal tear and was impacted there. Wanted to use both hands, so used a chandelier in this patient so that you have, you can use both your hands, you can do bimanual dissection. And the foreign body was impacted there in the retina, was slowly eased out. Then you're extending your primary sclerotomy itself, because you know that it can be brought out from there. It's not that big, it's still less than 5 millimeters, and it's brought out from the same wound. And then the break in the retina was treated, fluid air exchange, endo laser done, and silicone oil. Usually in trauma patients I prefer silicone oil. This is a patient with a metallic foreign body. I'll just go straight to the foreign body part. So always do a complete vitrectomy, use indentation, scleral indentation, clear the entire vitreous. If you need to do a lensectomy, also try and save the capsule so that you can put in a lens later for the patient. So here with indentation, completing the peripheral vitrectomy. And this is the metallic foreign body. So you would not have been able to approach this unless you released it from all its attachments. And now using an intraocular foreign body, and you can see how the foreign body literally jumps onto the magnet. So this was a magnetic metallic foreign body. And And then here using a handshake technique, because when you're bringing it out with the magnet, it can get engaged at the internal wound of the sclera. So this is the handshake technique. You are using an end grasping forceps on the other side and bringing it out through the sclerotomy because the wound was still small. This video shows an impacted intraocular foreign body. Sorry. Yeah. So if we're going straight to the where the foreign body you can see is impacted here, gone through the retina into the choroid and is impacted there. So initially I did a laser so that the retina around it, even when you're removing an irregular foreign body, sometimes the retina can tear irregularly, and this is so close to the disc optic nerve head on the nasal side, so you wouldn't want irregular extensions. Then with an MVR you're teasing out the foreign body which has been encapsulated. As it bleeds, you're using cautery causing hemostasis, because once the whole area gets covered with blood, then you can't really visualize the retina too well. So make sure you cauterize adequately, especially the choroid bleeds like anything. Sometimes it's very difficult to control choroidal bleeding. So you can increase the intraocular pressure. You can even use PFCL at that site to cause a tamponade effect and have hemostasis. Completely release the foreign body, teasing it out from the choroid and through the retina, and only once it's free on the retina lying there, then you can now bring in the magnet, and then you can see how it just jumps onto the force, and yeah, now you can bring it out completely. So earlier just going with the magnet for an impacted foreign body just won't help. It's not going to cause any effect, so you're going to have to bring it out. This is a patient with endophthalmitis. So you can see lot of usually endophthalmitis you expect in vegetative matter, organic kind of foreign bodies, but you can however get it with any kind of foreign body also. So a complete vitrectomy is done. It's a large foreign body, so had to get it out from the limbal root itself. Yeah, so already caused a lot of scarring on the retina, some amount of disc pallor is also there, and here you have to somehow innovate with improvise with every foreign body depending on how it's angulated. So used the same ILM forceps, only just widened it a bit so that it gives you a better grasp of the foreign body. And then, as I said, the handshake technique, you bring it out anteriorly, use another forceps to give you a better grip, and then bring it out through the limbal root. So the complications of foreign bodies could begin anteriorly with corneal scarring, with cataracts, glaucoma, siderosis, chalcosis, choroidal ruptures, detachments, retinal detachments, endophthalmitis, and sympathetic ophthalmia. And the prognosis usually depends on the vision of the patient at presentation. So usually 660 or better, will have a good prognosis. The more anterior the foreign body is, the better the prognosis is. The timing of surgery, we've seen that within 24 hours, if the patient has been operated, that leads to a better prognosis. And the health of the optic nerve, that means the presence of if the patient already had an afferent pupillary defect, then the prognosis becomes a little poor. So prevention is usually better than cure. We do insist on universal using of protective eyeglasses, whether it's with the construction workers at industry, to emphasize on the use and to give good quality glasses, because once they get scratched and those workers can't use those glasses, they'll just throw it off. So to emphasize to the owners also on how they need to upkeep the glasses, have a high index of suspicion. Early surgical intervention saves vision. vision and never give up hope with these patients. Good documentation. We need to cover our back also. So good documentation, counseling and medical legal cover is very essential. Thank you so much. And now I'd like to call upon Dr. Sonal Jadhav Laktawala for her talk on imaging in ocular trauma.
To give me a chance to be a part of this interesting IC on ocular trauma. We've seen amazing surgeries by Supriya for interesting IOFBs, but क्या करना है? नहीं, it's not coming. It's not connected. एक बार वापस connect करिए. Yes. I'm sorry for this. But I think, when it comes to ocular trauma, the most important is you need to evaluate the eye, you need to see the eye in detail, you need to see what kind of trauma, you need to see what is, is there a presence of IOFB? If you can visualize it, it's great, but if you cannot, then at least alternative techniques to visualize it. So you're very sure before you're getting into the eye and operating a patient, you have everything ready with you. I'm going to take you through a few important tests which are going to help us to evaluate these patients. There's no financial interest in this presentation. We all know that eye trauma is a leading cause of significant visual impairment, and almost about 2.4 million eye injuries occur every year. Bilaterally visual impairment in about 2.3 million cases, and unilateral loss in about 19 million people annually. It's the second most important cause of visual impairment. Almost one of every 20 patients by an ophthalmologist seen in the OPD can be because of an eye injury, and it's only second to cataract and strabismus as a leading cause of hospitalization. Dr. Korobi's already gone through the BET terminology, which satisfies all criteria for unambiguous standard terminology, providing a clear definition of all injury types and placing each injury type within the framework of a comprehensive system. We've known about the closed globe and the open globe injuries. I'm not going to go through this in detail, but you must understand that 77% chance is there to predict a final functional outcome in a patient. Appropriate counseling contributes to making the correct triage and management decision, prognosticate the outcome of injury, and easy to calculate and has major significance for the patient, the ophthalmologic, and other public health professionals. We know about all the closed globe injuries and the open globe injuries, but imaging is one of the most important things in the management of ocular trauma. Evaluation of the extent of injury, planning of the management strategy, follow-up tool, and medico-legal issues today have become extremely important in such patients. So assess, evaluate, and address. Physical examination is very important. A gentle separation of the eyelids may be required, and avoid pressure on the globe. Assess the visual acuity, naked inspection, and on slit lamp see in detail the periocular structures, the conjunctiva, cornea, sclera, pupil, anterior segment structures, and indirect ophthalmoscopy. 5 most important imaging techniques. X-ray is been the oldest and the gold standard. UBM, B-scan, CT scan orbit, axial and helical CTs, and MRI. This is extremely important when you are seeing a patient with a high velocity particle. You have no clinical evidence of ocular penetration, then I think no orbital X-ray or imaging is required. If there is a clinical evidence of ocular penetration, if IOFP is clinically visible, a plain X-ray can do. In a single IOFP, you may not need any further imaging. In multiple IOFPs, you may need CT. In no IFB visible, you may need CT scan. And again, in no IFB, you may need further case-by-case decision. If IFB is seen, then we don't need any further imaging. X-ray. This is the original method of evaluation and detection of IFB. This is the first thing I think taught to all residents in our ophthalmology days. A dental X-ray may be more helpful due to bone-free image. A use of a limbal ring is still used to localize foreign bodies, study the orbital fractures, and now it's become of medical legal necessity in some areas. It's commonly performed on ophthalmic patients with a history of exposure to high velocity particles and a suspected or clinically visible IOFP. It's useful in radio-opaque foreign bodies and will not detect radiolucent IOFP such as wood and glass. The standard foreign body X-ray series includes a Waters view, a Caldwell view, and lateral views. Plain X-ray films with Caldwell or Waters projections may demonstrate the presence of the IOFP, but it's not going to tell you the exact location. So the sweet localization technique involves frontal and lateral projections, a foreign body which can be beautifully localized within the globe with a bone-free examination by eye movement. So in case of a foreign body, in the anterior segment, the object will rotate in the same direction as the eye, but the object will move in an opposite direction, opposite to the eye movement if it is located in the posterior segment. Smaller things to just keep in your mind when you're seeing a patient for the first time. Localization using metal locators can be either placed on the eye with a contact lens or sutured to the limbus, which we normally do like a metal ring sutured around, and this may help localizing the foreign body either to the anterior or the posterior segment of the eye. So here you have different images. The first image shows you a teardrop sign which is seen classically in a blowout fracture. You can see that lower area. Then there is an IOFP which is detected with the help of metal locators. You can classically see the ring that is sutured to the limbus and the IOFP is seen. The next important and effective way of seeing and a non-invasive method is again UBM, but it's a valuable adjunct in the evaluation of small foreign bodies which are mainly in the anterior segment and the pars plana, and in evaluation of the lens and the angle. It may be especially useful for finding non-metallic foreign bodies and also used to determine the depth of a visible foreign body. So UBM again gives you an idea whether there is an evidence of angle recession there or not. If there is an iridodialysis, there is a presence of an IOFP, you can see a cyclodialysis, and you can even see if there is a patient, if the patient is pseudophakic, you'll be able to see the position of the lens, whether it's been damaged or it's in the AC. Ultrasound I think is most commonly used by all of us, and it also helps us to detect other important phenomena associated in trauma, which can be hyphema, traumatic cataract, vitreous hemorrhage. You can detect and localize intraocular foreign bodies. You can differentiate between serous and hemorrhagic choroidal detachments, and you can also see suspected posterior exit wounds with associated incarceration of intraocular contents, see the evidence of presence of RD or anything like that. B-scan can have a false negative result in small IOFPs or very large IOFPs, especially if the anteriorly located or irregular. IOFBs of wood and vegetable matter, long-standing metallic IOFBs, you will have a false negative result. A false positive can be in air and gas bubble and lens matters. It's useful tool in localizing IOFP and to determine if the object is metallic. It could be performed carefully in case of an open globe injury. It's useful in determining the extent of intraocular damage, determining the presence of a retinal detachment, double perforation, as well as in detecting foreign bodies not seen on X-ray studies. But it also gives you an idea about the nature of the IOFP, round or spherical, intraocular air or glass. The importance of B-scan, this is very important. B-scan will give you the nature of trauma. It will rule out the possibility of a foreign body. You can try to identify normal structures, and the most important part is that you should repeat a USG before you are planning the surgery for a patient. So scheduled surgery, successive B scans will help you to see the patient and go ahead with your treatment plans. B scans will give you scleral rupture, peripheral retinal tears, choroidal detachments. You'll have PVD with vitreous hemorrhage and retinal detachments. All the associated signs can be seen here again. A presence of a dislocated lens, a presence of an intraocular foreign body in the orbit, which gives you a sharp shadow. The limitations are that it's not recommended in open globes. Surrounding edema and injuries may cause difficulty in doing a scan, unreliable for detection of orbital foreign bodies, poor demonstration of extraocular muscles, limited view of the optic nerve and retrobulbar structures, and scleral ruptures. The next modality is CT scan. Today is considered as having advantage due to its ability of performing multiplanar reformation, evaluating intraorbital structures with simultaneous imaging of the bony orbit, of fractures or any herniations into the orbital contents. So, a sensitivity of 45 to 60% for IOFP, which is less than 0.06 millimeter, and 100% for IOFBs, which are more than 0.06 millimeter. CT can miss plastic, even metallic IFBs, especially if too wide cuts are used. So it's very important to have small cuts, that is about 0.5 millimeter. A helical CT scan is an advantage over the axial CT scan, has a shorter examination time, and images much more superior to the conventional axial CT, has the ability to reconstruct a coronal or a sagittal image without further scanning, and reduces your motion artifacts and radiation, and has a high identification rate for glass foreign bodies. When you have no view of the posterior segment or a suspected globe rupture or a laceration or an IOFP in an open globe and associated orbital of facial fractures, CT becomes the choice of investigation. An axial CT and a helical CT comparison with a glass foreign body. The disadvantages are that it's not readily available in pure or purely ophthalmic setups. Intraocular structures are not well imaged, and it can miss plastic IOFPs. It's avoided in pregnancy. MRI is again very sensitive in detecting wooden IOFPs, controversial in metallic IOFPs, superior image quality of the soft tissues as compared to CT, and ability to generate axial coronal sagittal views simultaneously, and also gives you an answer to the optic nerve damage. But again, the disadvantages is that sometimes expenses can come in your way, motion artifacts, contraindicated in patients with pacemakers or magnetic IOFPs or cochlear implants. Claustrophobia today becomes one of the biggest reasons for patients not getting into MRI machines, and less effective in CT than CT in assessing orbital fractures. Choice of investigations today also in orbital fractures remains CT and X-ray. In metallic IOFBs, open globe, orbital, you do a helical CT with thin slices. If it's a closed globe, your ultrasound UBM take the chance. Non-metallic foreign bodies, you still prefer ultrasound, UBM, MRI. Penetrating injuries, CT to assess the orbit, sinus and brain damage. And in acute orbital or ocular injury, a helical CT without contrast. Thank you so much. Thank you. I would like to acknowledge Dr. Muna Bende, Dr. Deepak Bhatt, and Dr. Supriya for giving me such good images. And I would like to invite our last speaker, Dr. Sugneshwari, for giving us again, I think, a very interesting talk on minimal vitrectomy. How to attach it? It's such a
exactly I'm going to be talking about. We are going to be talking about only a part of the trauma. This is called retinal incarceration. What new do we know about it? So coming to traumatic retinal incarceration. So this is a topic which is like something which is not everybody is aware about. The first one, yeah. So what exactly happens in a traumatic retinal incarceration? There are too many things that we should understand, that some terminologies may be overlapping terminologies. When we talk about traumatic incarceration, I'll be coming to that in a short while from now. So what new is what we are going to be talking about in the traumatic retinal incarceration. So posterior segment injuries, as we all know, has vitreous loss, incarceration of the vitreous, the retina, the choroid. Progressive scarring, this is most important thing what we should understand. Shortening of the vitreous and the retina. We have better understanding of the diseases nowadays, so we know what to do, when to act. And tears at the incarcerated site. So what is traumatic retinal incarceration? prolapse of the vitreous, uvea, and the retina into the scleral wound. This is called traumatic retinal incarceration. Now the mechanisms, I am not going into it. Now this is not something new. The classification of retinal incarceration, this is not new, but that's something which we have all forgotten, which we are revisiting today. So what is class 1? Class 1 is anything in the posterior zone. Posterior zone means it's the region which is going to be posterior to the vortex vein ampulla. 1A means macular involvement, which means it is within the 2 disc diameters of the fovea, you have an incarcerated wound. 1B is no macular involvement, which means it spares the central 2 disc diameters. And what is class 2? It is equatorial zone. So which means the region from vortex vein ampulla to the aura. This is called the equatorial zone. And when you have an incarceration at the anterior zone, that's coming to class 3. It's the region anterior to the aura. Now, if you have an incarceration at these levels, it's very important that we know where exactly we have to plan our plan of management. Now, how do we diagnose a retinal incarceration? So, retinal incarceration is diagnosed by ophthalmoscopy if you have a clear media. If you have a hazy media starting from the cornea up to the vitreous, so in that case, corneal clarity is not there, or you have hyphema, or you have a cataract, or you have a vitreous hemorrhage, then we don't have a view. So then in that case, we need to do the ultrasonography. So here there is an ultrasound which you're all seeing. So what exactly do we see here? You can very clearly appreciate the vitreous tracking into the retina. So this is what it is. And then intraoperative visualization of the fundus is important. So now what is the timing of surgery? We all know the timing of surgery is a balance. That is not a static value. Please remember, there is no standard rule that you have to be taking the patient only on this time. No, you will take the patient when your inflammation settles and the engorgement of the eye is coming down and the risk of developing a closed funnel retinal detachment is not there. So you have to time your surgery in between these two things. Ideally speaking, 10 to 14 days after trauma is what we have all learned and we all know. And the factors which helps you in making a decision is whether or not you have an IOFB, what is the nature of foreign body, metallic or vegetative, then in that case your vitrectomy has to be very early, or presence or absence of endophthalmitis. So these dictates when you will time your surgery. What do we have in terms of understanding of an incarceration? The incarceration of the fibrovascular proliferation, what does it do? It produces shortening of the retina and it prevents the contact of the retina with the RPE. So what are the goals of surgery? You relieve the traction by islanding. So we have to island, that's what is the principle. Removal of the scaffold, every scaffold has to be removed and you have to excise the peripheral retina if you have an incarceration at the periphery to preserve the function of the posterior retina. What is the choice of procedure? The advantage of vitrectomy is removal of the blood and the other pathogenic stimulants which can hinder the wound healing, and it includes the vitreous scaffold, the proliferating cells and the serum products. What is the procedure in detail? You complete the vitrectomy with a posterior hyaloid removal, removal of the vitreous from the incarcerated site to minimize the subsequent proliferation and the traction, removal of all the membranes, whether it is the epiretinal or the subretinal, placement of the endodiathermy, that is to demarcate the desired area and also to have a good hemostasis. Now, where do you place the retinotomy? This is what is most important. If you have an incarceration in the class 1, then you will have to place your retinotomy as a circumscribed retinotomy. If you have a class 3, then your circumferential retinotomy is what is going to help you, and this is performed so that the posterior of the incarcerated site to allow the repositioning of the displaced retina into the more posterior location against the RPE. Now, how do you make the retinotomy? You may use a scissors or a vitrector. Some of us may even use a flute. That's personal choice of the surgeon. And how do you minimize your retinotomy? You must be as close as possible to the incarcerated site in small increments. You don't go zoom past in that, go in slow segments. So to minimize the size of the resulting retinal defect. So this is where it would vary from when you are performing an RR for in a PVR case in a rhegmatogenous retinal detachment, that's going to be different. That we are all taught large is better, but here the small is better. Now what and how do you proceed? You attach the retina now with whether you use LPFC or you're going to use your gas tamponade, the air tamponade, and then the margins of the retinotomies are treated, then you use a tamponade gas or oil. So now this is the same fundus of the patient whom I showed you the ultrasound. So the ultrasound is very, very classical that you should be able to identify on the ultrasound. Now here I'm going to show you two cases which I've operated. This is a case 1 wherein it's a 9-year-old male with history of blunt trauma, the break at the infratemporal quadrant with the vitreous incarceration. So here it's only the vitreous into the subretinal space. So what do? The choice, there is no buckling here. It's only the vitrectomy with a belt buckle with an endo laser with a gas. So you may ask, why not a scleral buckle? It's a peripheral break. Yes, if you use a scleral buckle in this particular patient, you are going to have herniation of the vitreous gel into the scleral wound. That's why you're not going to be using a buckle on that. So now coming to case 2, it's a 52-year-old male, injury with a tree branch, came with hyphema cataract. So now on the ultrasound, you are seeing the vitreous into the retina into the choroid. So this is what you should understand when you have an incarceration of these tissues. What we do is we try to island. I told you island, and the retinotomy has to be close because you are having it very close to the fovea. So we have to island it here in order to attach the retina. So that's what we have done. Now what are the complications of an extensive relaxing retinotomy? Hypotony, epiretinal membrane, large field loss, a PVR with recurrent retinal detachment, extensive ischemia leading on to neovascular glaucoma. So now coming on to what is new then in these things. BTEP, what is that called? Beyond the edge proliferation. So after a relaxing retinotomy, what we get is called as beyond the edge proliferation. One must be very cautious about this. Why does this occur? Because the proliferation is anterior and it is contiguous with the relaxing retinotomy. It is an unusual, but it is called one of the types of proliferative vitreoretinopathy. Now you must all understand that here OCT comes into easy help for us to identify or rather delineate or understand the structures better. So what I have written here as AR means it's an attached retina. So you can see that's a good attached retina over there. And the mark which I have given it as yellow TS, it's a traumatic schisis which is there. And then the RR points to the site of the relaxing retinotomy edge which is attached in this patient, and beyond that BTEP is there. You have the beyond edge proliferation. After that you see the bare RPE, which means now this is the separation which has come. So these are the things which are the trouble after you operate on a patient with a retinal incarceration. How early do these BTEPs occur? As early as 5 weeks. And then what is the cause? It's post-anterior traction, and the location, inferior interface between the aqueous humor and the silicone oil or the gas. So you may be wondering, why am I telling aqueous humor in the posterior chamber? Once you remove the vitreous, there is no vitreous over there. It's all the aqueous which fills in. So what is the reason? Compartmentalization, the concentration of blood, the RPE from the areas below the RR is the cause for this. Now you should also know that we should be able to differentiate the BTEP from what is called as SIRF. What is SIRF? It is nothing but the severe inferior retinal folding. So what we see in these patients are like your RR edge is going to retract and come away, your laser scars are going to be lying bare over there. So this is what happens in this, but this happens in a rhegmatogenous retinal detachment. So next thing is relaxing retinotomy edge fibrosis. This is when you have membranes which are there, epiretinal, which can cause contraction and thereby providing the fibrosis. So you will have to differentiate this from BTEP. What next? So if your PVR is the causative factor for all this BTEP, what do you want to do? You would like to do a chorioretinectomy, in which circumstances perforating globe injuries with an exit wound at zone 3 or zone 2, severe IOFBs. What do we do in this? Removal of the incarcerated retinal tissue from the underlying choroid to the level of the bare sclera. So you remove all these tissues in toto, 360 degree around the impact of perforating site of the foreign body using a vitreous cutter. So this is what I've done for this patient. Inferiorly you can see the margins of the chorioretinectomy. But believe me, when you do this, you will have to be as early. Like Dr. Natarajan pointed out, it has to be done within 100 hours of the primary surgery. If delayed, it's very difficult to perform this. So it is performed in the perforating eyes so that you may prevent the PVR related complications. So to conclude, the period between the primary repair and the vitreoretinal surgery is very crucial. It is not one single value. It has to be well titrated by monitoring the patient and take the call when you can do a safe surgery. That is what is important, not doing surgery, but a safe surgery. An equatorial or peripheral incarceration, you may support it with buckle. The size of the retinotomy is directly proportional to the site of the tissue incarceration. Anatomical restoration depends on extent of retinotomy. The vision depends on the location of incarceration. So this is what I have for all of you today from Shankar Netralia. Thank you for your patient time today. Thank you.
Thank you, Sugneshwari, for the wonderful talk. I thank all the speakers for rendering their talk so well. If there is probability, might be for one or two questions. If anybody has any question for the speakers, please feel free to get up and ask it. And in case you have no questions and everyone is hungry, then we can all split. Thank you very much for your kind attention.